welcome to this keynote on triaging with staff and patients in mind. My name is Mahir. I'm a community manager here at Accurx, and I'm joined by Bex Cottey, business manager at Conisbrough Group Practice in Doncaster. The practice has been doing total triage for over 2 years now. So thanks so much for joining, Bex. We did have some IT issues just before we started the session. So I'm glad that that's resolved and you can join us. So really appreciate you joining, Bex.
You're welcome.
Bex is actually one of our Accurx ambassadors who regularly train other practices that are looking to move to total triage. I'll share more information on how you can book those training sessions very shortly. But yeah, Bex's practice has been doing total triage really well, and they've trained dozens of practices who are looking to sort of move on to that model. Just a couple of housekeeping notes before we begin. This session is being recorded, so I'll circulate a recording of this session shortly afterwards in a follow-up email. So if you have colleagues that maybe wanted to join and couldn't attend, feel free to share that link with them. Just keep an eye out for the email. And if you have any questions for Bex, please post them into the Q&A section. Otherwise, this will be a very short session. We're hoping for lots of questions from you guys, so please do try and spam us with it. I also have some of my colleagues on the call that will assist with some questions in the chat, so keep an eye out for any questions that are answered that way. But please, I encourage you to ask as many questions as you can. So what are we going to be talking about today? So we'll cover what total triage is and why it's becoming more and more popular. You might have heard about it a lot more now than you ever did before. We'll then hear from Bex throughout the session and around Conisbrough's sort of total triage experience. And again, please ask as many questions as you can in the Q&A. And then finally, I'll just share some resources that you can sort of tap into if you're looking to move over to a total triage model. We're here to support you in making that move, and we've collaborated with hundreds of practices to sort of build those resources that we found have been really effective in that journey. So without further ado, what is total triage and why is it becoming more popular? I think before we get to that, it's important to illustrate the trend that's been happening in general practice, where we've seen practices that are struggling with limited resource in an environment where demand essentially has increased. Our team at Accurx have done a lot of research on the different ways that practices can, deal with patient inbound. So we're quite familiar with the total triage model of working. And as I say, you've likely heard of this term before, as well as newer terms such as modern general practice access. They largely have one goal in common: to manage patient access and demand more efficiently. So just to illustrate using this example that I've got on screen here, we've spoken to thousands of practices over the years and have seen traditional GP models where a patient either walks in or calls the practice, usually in the morning, leading to an 8 a.m. rush, which is a poor experience for both patient waiting on the phone as well as reception staff. We've also noticed that this traditional model can involve, running multiple different processes in parallel. So, the process of record keeping for each contact point, they can be vastly different from each other. That then can lead to patients being given an appointment by default, for example, or signposted inappropriately, essentially allocating resources that may not always be necessary for them or clinically appropriate. And we found that if that patient doesn't receive appropriate care, they may need to, repeat this cycle all over again and go through that poor experience. So it's almost like it fuels this cycle. Now, Bex, why do you think we're hearing about total triage more than before? And would you say that this model on screen here is kind of representative of the realities that lots of practices face today?
Absolutely. I think word is starting to get out about total triage. I think the initial thought of many practices was we're not big enough, or we don't have enough staff to do this, or our patient population won't adapt to the new technology, they don't want it. There were quite a few, I mean, we were concerned as well before we initially started that if you do this, you're going to open the floodgates, that you're going to have a system where it's unmanageable, everyone will have access to you all the time. And so there's a lot of concern behind it. And we completely get that because we were there before we started this journey. And for us, it was out of necessity to start because our telephone systems went down and we had the software already. We just hadn't dared to turn it all on. So I think that's why it's starting to come into focus now. People are realizing that practices of all sizes and all demographics are actually finding it beneficial.
Yeah, that's really interesting you say that. I think from speaking to practices, a lot of them have this fear that, you know, using online consultation does open the floodgates. Would you say that when you did sort of go live with the total triage model, then did you see that happen, or and did it sort of flatten out, or like what was your experience around that?
Right. So initially we did have an influx. I think it was a very positive influx that patients were like, oh, something new. I can do this. I can do it in my own time. I don't have to be sitting in the queue on the telephone waiting to get through. And I think we did have a big influx to start with, but it was very short-lived and it flattens out. And it also flattens out throughout the weeks. We still have peaks and troughs, but you can manage those peaks and troughs with staffing, with, you know, we all know that Monday morning, regardless of what system you're running or what part of the country you're in, Monday morning will always be a high demand time. And most practices are well staffed on a Monday morning to manage that historically. And that's where we do find it comes in. So we have a nice U-shaped, not even a U-shaped curve, a downward curve to Wednesday. So Monday's the highest, Tuesday it starts to come down, Wednesday's quite low, Thursday's actually our quietest day. And then there's a little uptick on Friday as people approach the weekend and realize, oh, if I'm going to see the doctor this week, I ought to get in quick. So yeah, that's what we find.
That's really interesting. Thank you, Bex. So, I mean, this is a great segue into the model, the solution that we're seeing lots of different practices kind of adopt. So the model that I have on screen here is almost like a typical, templated total triage workflow. The basic premise or principle is triaging based on clinical need. So total triage is a workflow within general practice where sort of every patient is triaged before an appointment is given, if one is even required at all. And the benefit of using Accurx is that you're able to sort of funnel those requests into one inbox, get visibility of all of your workload, and that makes it easier to resolve those requests that can be done asynchronously more efficiently. You can promote digital access with total triage, and often, correct me if I'm wrong, Bex, but like the majority of practices and the majority of patient requests come through that way. And patients still have that option to walk in or call in the cases where they don't, where they're unable to use the online form. And with Accurx, you're still able to record those in the same way using our reception flow feature, which I will talk about a little bit later on. But Bex, what would you say around like the whole idea around access? And, you know, we've already kind of spoken to opening the floodgates because maybe the perception of access becoming too easy, but like what is your thinking around access for the patients that might not be as tech savvy as others?
Okay, so we had a lot of our preconceptions absolutely smashed by our patient population when we first started. We expected it only to be the young patients who have grown up with technologies and are not afraid to try new things. They'll just jump in, try it, and if they like it, continue. And it would be the older population that would struggle. And we actually find that we have plenty of 80-year-olds, in fact, a 90-year-old, someone in her 90s also accesses triage herself from home. It's on the desktop because she has a little computer or a laptop at home rather than on the phone. It becomes quite a flattening way, an accessible way. We've also done some work with local organisations such as Citizens Advice about digital deprivation, so people that might struggle to have access because of lack of data or technology at home or reliable Wi-Fi or credit on their phone, etc. So there are issues that we need to be aware of with any technology, but generally we've found that the younger and the olders really love this, and we have a slightly sticky population in the middle, somewhere around 50-year-olds that are most resistant. But it's a generalization, and I've just have our patient triage desktop open at the moment, and I can see that the way in which patients are submitting requests, we're only getting about 15% of our patients needing to come through our reception team, whether that's front desk or telephone. 15% is very small now. And like you were saying before, our reception team used the Accurx flow so that everything comes to the triaging clinician in exactly the same format, regardless of how the patient wants to access our practice.
Yeah, that's really interesting. So by funneling all of those requests through that one inbox in a standardized way, do you think that supports, you know, a fairer triaging process then? Because, you know, you're effectively collecting the same kind of information from each patient.
Yes, it provides equality, because those patients who can't or won't use technology have more access to us on the telephones, because the telephones are not as busy, or they prefer to, you know, get their fresh air and come and walk into the front door and go to the reception in the morning. Same thing. We ask for exactly the same information in exactly the same format, and our care navigators or our reception team know the level of information that is most useful for the person doing the triaging. They've seen examples of good submissions, useful submissions. So if a patient is a little reluctant to give detail, then they can encourage the patient to give that a bit more to help them access. And that's explained to them at the time. So patients are constantly learning about what's the best way for them to get the care that they need when they need it. So we do a lot of patient educating in a very roundabout way. It's not direct education. We're not telling them what they have to do, but we do just keep informing them and updating them and explaining to them why we use this process and why it's fair and why it doesn't matter how you access, you get the same level of care from our clinicians.
And do you find that patients are quite understanding of that, or
very understanding,
accepting?
Yeah, very understanding and accepting. They don't, you know, some people will then also say, oh, I might give that a try. We also have people that say, find it really useful because you don't have to register or have a code or a password to get in. It's just there on our website. And if you're a patient of ours, it will connect and send to us. And it means that you can be take over a proxy access for somebody. If you're a carer for somebody, it means that you're not putting up barriers for people to access. If somebody there has somebody that is looking after them, even if it's only temporary, they're coming out of hospital and think, I need to get them to the doctor, but I'm not well enough. I can ask my son, daughter, mother, whoever, carer to do that for me. So it just leaves that door open and accessible to anybody, regardless of what your situation is.
Great, thank you so much. For those that aren't familiar with patient triage, which is our online consultation solution, I thought I'd just give a quick whistle-stop tour of what that kind of involves. So there's a short patient form involved that can be submitted by the patient online or using reception flow, as we just discussed. And that ensures that patients are treated on a sort of need-based model rather than, you know, first come, first served. And the questions are standardized. So you can improve your record keeping within the clinical records. And that form is so simple. 86% of patients rate that online form as easy to use or very easy to use. And then once that request actually comes through, you have a powerful inbox where those requests get funneled into. That's fully integrated with your clinical system. It's equipped with a bunch of tools that you can use to effectively manage that request. So much loved features such as self-book, questionnaires, and you can kind of use that all to sort of navigate that patient's care in the most appropriate way. And finally, you have access to really powerful data dashboards, as well as the ability to customize some of your settings so that you can track, plan, and manage your demand, and sort of do that capacity planning where, as Bex mentioned early on, you know that Monday is busier than any other day of the week. With patient triage, you'll be able to see exactly how much busier that is. Essentially, it helps you get a little bit more of that control back in your practice capacity. If you don't have access to patient triage and you're kind of interested in seeing a demo, I will give a bit more information right at the end of the session on how you can get that. And we also offer a 3-month free trial as well, so you can make use of that as well. And I'll also share that in a follow-up email. I think the next slide, we kind of spoke about this naturally already, but patients that can't access or use the online form, so reception flow really leaning into this here as a way to make this process more equitable and fair for your patients. So those that aren't as digitally literate, they still will benefit from this model. Essentially, this feature facilitates you to become a digital first practice without foregoing patient access to care, which is kind of like the reason why you're doing this to begin with, to be able to keep up with that demand. I'm just reading my notes. I did have a question there for you, but I didn't quite complete it. But Bex, I mean, I guess we kind of already spoke about the benefits of reception flow, and how roughly 15% of requests that you receive are through the receptionist. Did you find that as part of reception flow, when the receptionist is sort of taking those details, is there an element of educating that patient that there is this process in place, and patients can access digitally, to sort of educate them for future cases where they might need to contact their GP? Is there anything along those lines that you kind of implement?
Yeah, absolutely. So early on in the process, we asked our reception team to slow down on all their telephone conversations and allow themselves time to explain to the patient that we have this new service. Would they like to try it? If they would, then they would send them the link there and then, and stay on the line and walk them through the process with them, handhold them through their very first mission to see how easy it is, and then the next ones they can do on their own. So that was one thing that we did as part of our implementation, and people were surprised at how quick it is. When we first said, "Oh, can I send you a link?" They were like, "I'm not really, I'm not bothered. Can I not just tell you what I need?" But just a little bit of encouragement and a little bit of pushback to just say, please try this if you have access to the web, and it's worked really, really well. And our numbers, the ratio of numbers of things coming through on the telephones and face to face at the front desk compared with online has just slowly shifted. And like I said, we're right down to 15% reception work now. So it frees up time for your receptionists to be doing other things as well.
That's great, thank you. So this slide is dedicated to you, Bex. Just a reminder to the audience, please ask questions in the Q&A. I believe there may be some there already, which we can kind of go through anyway. But Bex, just to give a little bit more of an intro, could you tell us a little bit about your practice, when you began Total Triage, and like what were the key things that sort of made you reflect and be like, okay, things need to change?
Okay, so prior to the pandemic, we were a telephone triage practice. So we were triaging calls that were coming in, but it was still all calls, all telephone, or face to face at the front desk. And what would happen was the patient would contact reception team. Reception team would then send the call to one of the triaging team. And at that time, we had all our partners that were in on any given day triaging. And then they would often have to call the patient to get more information to then decide which clinician was best to see them. So it was kind of patient calls us, we call the patient, we then call the patient again, or we see them face to face. And this process is exactly the same, except it cuts out that middle call, which is actually a very difficult call to have with a patient. It's really hard to call a patient and make them realize that your call is not the actual consultation. I'm just wanting more detail to find out who's the most suitable practitioner for you to see. So, as I said, we went through a tumultuous time shortly after, as we were coming towards the end of the pandemic a couple of years ago. We changed to telephone providers, and we had a period of time of 2 weeks where we had a very unreliable telephone connection. So we had some days we had no phones at all. Some days they were hit and miss, etc. And patients were just absolutely grumbling, can't get through. We had queues out of the door. And we said, hey, look, we've got Accurx on our desktop. We've been using it for inviting patients for their COVID vaccines as part of the national campaign. And it has so many more tools within it. It has this patient triage. Shall we use it? Shall we just try, put it out there, see what happens? At least it gives our patients a way of contacting us. And we also knew at that point, because we'd had a little look at it, play around with it, that we could have an emergency cutoff. So we said, let's just open it. If we absolutely get overwhelmed and we'll just turn it off for the day, catch up with ourselves. And we were just, for us, it was very much a suck it and see and give it a go and see what happens. So we had to evolve and develop and change literally day by day as we first did it, because it was a case of do or die. So, and the response that the immediate response we got from patients was overwhelmingly positive, because they could see we were trying to do something to help them contact us in a situation where they couldn't call. And B, they were realizing that actually by using this little link or going on our website to access the link, it was a very, very simple process. And so we built it from there. So then when the phones did come back on, we spent the time educating everybody else and saying, have you tried this? If you haven't, I think you could and you should. It's really good. And we just opened it up for everything, for our repeat prescriptions, if they had admin queries, test results, etc., etc. And we've developed over time.
That sounds really interesting. Yeah, I've never heard of a case where it almost happened out of necessity by accident because of the phone lines not working. So that's a really interesting way of kind of approaching it, but really good to see that you kind of saw the benefits of the model straight away and of the functionality. So really nice to kind of hear that different way of approaching it. How long would you say it kind of took you to implement that system from start to finish?
From start to finish, we were comfortable and familiar after a week, and then we've tweaked things. I mean, we still tweak things now. We still look at and we still use because the dashboard now is just so much more useful to us as an individual practice to say, oh, look, we have lulls here, or you can look at trends, not just across the week, but across months and across years. Now we've gathered that much data, and we can look at when we might want to run certain campaigns because we have less pressure in certain months, or parts of the month or parts of the week where we can say, you know what, now would be a good time to be offering extra services that help with our practice income, such as we'll put on extra minor surgery clinics or something like that. So it's really helped us remain flexible and learning for ourselves as a practice and developing ourselves as a business.
I think there's a really important sort of takeaway there, in that general practice is constantly evolving. So you're going to have to tweak your workflows all the time, essentially. So committing to a model or committing to starting a total triage model it doesn't necessarily mean that the way you work in the first month of kind of implementing that model is the way you will always work. You're always kind of trying to figure it out and make enhancements and tweaks here and there. And the data that you can get through Accurx is kind of able to help you do that, as well as make efficiencies in things like long-term condition management, as you said. You know, when you're running campaigns, you kind of know when to plan them. So that's really interesting.
And staffing levels change. You know, you might just suddenly go, you know what, we've got a nurse who's resigned, or we've got a doctor that's on long-term sick, or whatever. It means that you can then say, okay, how is this going to impact the way we work and the appointment systems that we've got in there, because we use self-book appointments for patients for certain appointments. So you can just adapt according to patient demand, staffing levels. You know, it just allows you to be more flexible and responsive to the climate.
And just remind me, Bex, what does your triaging team workflows kind of look like? Who sits on your triaging team, and how do you kind of manage a patient request?
Okay, so our triaging works, we have 6 partners at this practice. So each of the partners is triagers. We only limit it to the partners rather than salaried GPs, or we're also a training practice. We teach our registrars how to do it, but we don't rota them in to do it. The partners triage, and what we say is, for our level of patient capacity and our staff capacity and so on, we insist that we have 2 people triaging for the first 2 hours of every day as a minimum. So if there are more people available in, then great, we get through things quicker, it's more efficient, we can then have time for more admin or whatever, or seeing more patients themselves. And then 1 person for the whole day, and that is the on-call doctor, remains monitoring that triage box and remains distributing the workload as it comes in. So that on-call person doesn't see patients that day. They are there to support the practice staff in any clinical backup that they need. They are there to continue with the triaging of the day. And they often, when I say they don't see patients, they will often deal with the very quick, oh, that needs a quick phone call, or I can send a text message back on that one. And that's what they're doing in the day. They're just monitoring that stuff. Anything that needs to be seen face to face, then they can send out. They're constantly liaising with the reception team about, okay, this patient would be benefiting more from MSK referral, or pharmacy first, or whatever, or all the myriad of services that we can refer into now. And that's what they do. They wear the sorting hat for the day.
Nice. Yeah, I think one of the main concerns that, from speaking to users, that we've seen where practices are kind of hesitant to switch over to a total triage model is this idea around getting the clinicians on board. Nobody wants to sit on a desk going through 100 triage requests in a day. What was how did you approach getting different members of the team at your practice involved and on board?
Okay, so prior to this, the partners in particular were already doing the telephone triaging and found that really difficult, because some of them were very good at that very quick call to say, this isn't a consultation, I just need more information, I'm going to make an appointment for you. And others got sucked into that conversation that ended up being 15-20 minutes long, because the patient wouldn't get off the phone and did consider it a consultation. So when we moved on to this, they were like, well, this is great, I can make an assessment, I have all the information I need, and if I don't have enough information from the patient, I don't have to get sucked into a conversation, I can just send them a text asking for more information. I know that person will respond to a text because they're tech savvy enough to have completed the form in the first place. So we've then also developed lots of florries and text messages, instant templates to send back to patients as well. So there's been a change in the way they've been thinking about it, but it's made everybody much more efficient. So much so that although you said, oh, nobody likes sitting at the desk all day just sorting through all this stuff, they and I know a lot of people, when we've had been on the WhatsApp group, have said, oh, how do you overcome the fatigue of decision making? This whole process has meant that for the first time in many, many years, the partners can plan a break every morning and afternoon to actually just sit down away from the desk, have a cup of coffee, relax, just, you know, catch up with each other, check in with each other. It's much better for their mental health. They're away from the desk for a good 15, 20 minutes. They're then back on it and they feel refreshed. And they actually feel like they've been working as part of a team rather than feeling so isolated in their own room or just stuck in, you know, in what would be a call center, really. So it's actually been much more beneficial to everybody here.
That's amazing to hear. Yeah. I mean, we've heard countless of other examples where, you know, staff morale has kind of improved, and we've heard stories of, oh, staff are able to kind of leave on time for the first time in ages since implementing the model. So, you know, all very great stuff. I think I'm very close to switching over to questions from the audience, but I've just got one more from myself. So you're obviously training lots of different practices as part of the ambassador scheme. What would be your biggest advice to someone thinking of switching over right now? No pressure.
Okay. First, if you genuinely have these fears and you're feeling the pressure from the ICB to change into this new way of working, because, you know, part of the modern general practice model, if you've not already applied for funding, apply for funding and use it to have a little bit of extra locum capacity. You get the software involved, then you have an extra clinician to just say, you know what, if we do get swamped, we've got an extra pair of hands that we can be booking into. Come and see how other places do it. It's not a cut and paste into your practice, but many surgeries that are ambassadors that are doing these things will be able to talk with you through your current setup about the ways in which that you could adapt the methods of working to your staffing, the types of staff you have, how many staff you have in your patient population, and so on. So there is a lot of help out there. Everybody who's doing this, I think, is quite evangelical about it now and very passionate about wanting other people to benefit in the same way they have. It's not because we're wanting to force everybody to do everything the same way. It's just saying, this is great. I've not yet, and I'm sure Accurx probably haven't either, but I've not ever heard yet of anybody who's moved to this and it's been a negative impact on their life. Everything has improved. And those people that come and see us just say, for a start, they come and see how we do it, find it super interesting, and it gives them the confidence to go back and say, okay, now I know what to do, what my next steps are to get this going and off the ground. And they also feel much more kind of empowered to be able to go back and persuade other people of its benefits because they've seen it in real life.
Nice, perfect. Thank you so much. Just as an FYI, you can book a total triage training call with Bex or any one of our other ambassadors using the QR code on the screen. But then I'll also share that link in our follow-up email, which you can share with any other staff that might be keen on joining those. I might just keep it on the screen for a while whilst I run through the Q&A from the audience.
Okay.
So we've got a question here. Do you reserve all of your face-to-face and telephone appointments for triage? Do you give any appointments away for things like smears, etc., without triage? So
our nursing capacity is often done via self-book rather than through triage. If there is something come through on triage that is for the nursing team, then we allocate that to the nursing team to manage themselves. So they can see, okay, there is somebody who needs stitches removed, or they might need a smear, or something routine. Then they manage that, and they can manage it with the admin team by sending out self-book appointments.
And have you done any data analysis on like the balance between telephone or face-to-face appointments?
No, but we have found as the time has gone on, we are more and more confident in managing things over the telephone. Not when we're saying, it's not a way of saying, oh, we don't want to see the patient, but there are so many more cases now that we can just say, we can deal with this on the phone.
Great, thank you.
No numbers, but yes.
And a question from Jade. If a patient attends the surgery and informs the reception team that the problem is private or personal, how would you go around that situation?
Yeah, so we have some patients that do that. We have some patients that do that on the telephone still. We even have some patients who fill out the triage form and write, it's private, because they're not understanding that actually this information, although it's being typed in, will go directly to a doctor for assessment. And so we have a template for those that fill out the triage request online that way and just say, this is from a doctor. Can you tell me what's wrong? But the reception team are very sympathetic and understanding, and just ask the patient to describe it in a way in which they might feel comfortable, but have enough information for the doctor to make a decision, and explain to them that this is not because the clinician or that because the receptionist is making a decision, but that the doctor is making a decision and needs the information to do that.
Great,
I would
really helpful.
9 out of 10 times it works. Other than that, you can say to them, look, I can put this very bare minimum information, but please expect a text back to you from the doctor, and this may delay the time in which we can see you.
That makes sense, yeah. Thank you. There's another question from Jason. How is the inbox managed if you have multiple staff doing the triage? How do you prevent submitted consults missed or duplicated if it's been actioned?
Okay.
Sorry. I can just speak to the product side of things for this really quickly, and then Bex, maybe if you just talk about how you kind of manage that. So with patient triage and the inbox, you have what we call multi-user collaboration features, where you can actually see if another staff member at your practice is actively looking at a request or typing out a message. So you can use that, and then we have assign functionality, which you can use to assign the request to yourself, for example, so that it's outside of the main inbox. And finally, once a request has been actioned, the best practice that we've seen amongst lots of different practices is marking that request as done, which actually archives that request. So once a request has been actioned, it's away out of sight and it's been completed. But Bex, do you have any other kind of comments or advice on that?
Yeah, so we use all those features. We have to look out for each other on there. So, oh, somebody's already looking at that one, I'll leave it. And we also, if there's only 2 or 3 people in triaging that day, we might say, right, I'm going to keep an eye on capacity and be looking at, and I'll be, and you know, one person just saying, please sift through the list, see if there's anything that you can see that instantly needs just telephone calls or needs more information. Another person start at the bottom of the list. I'll start at the top of the list. So it depends on who's working, but we are, as a practice, we're very, very lucky that we've allocated one specific room for the triaging room. It's a triage room, and everybody sits together. So there's a lot of cross conversation, and it means that they can learn from each other in their triaging styles. So they've all become much more efficient because they've learned tips and tricks from each other in triaging, because they're there in the same room and they overhear each other and they see how each other works. So it's much better for collaboration. And I'm perfectly aware that not many practices are as lucky as we are to have that space. But if you can convert a room or a space or a corner of a room so everybody's together, it does bring a team together.
Yeah, I've seen plenty of examples in lots of different practices where they physically sit in the same room, the triaging team, and they're able to quickly like go over their shoulder and ask a question. It is a really great for team morale and a teamwork element. Another question from Matt: what ratio of triage work is clinical versus non-clinical? Thinking about dashboard inquiries, complaints, general queries for secretaries/admin. Does the doctor triage this too in a total triage model?
So in our model, the doctor leaves anything that's not medical, and our reception team go through and they allocate prescriptions to the prescription team, requests to the prescription team. Anything that might be about referral, chasing up a referral gets sent to the secretarial team. So, but there are people in reception. We have an on-call receptionist who is the channel in which information flows between the on-call doctor and the on-call receptionist, so that the on-call doctor isn't bombarded with messages from everybody, and they're responsible for sifting out anything that's not medical, and they go through that. I was just going to have a quick look at the types of requests we have so that I can see what the proportions are. So types of requests, medical requests obviously are the biggest input. I'm just looking to see if we can see what the numbers are. Beginning of the year till today, just over 15,000 medical requests. Repeat prescription requests is at just over 3,500 something else requests, and a lot of the time people will put in something else requests even though it's medical. It's just over 1,000, and then sick notes also over 1,000, and then test results, referrals, and doctor's letters are very small.
Is that from the beginning of the year, did you say?
Yes.
Okay, interesting. Another question, are there any flagging of requests if something seems urgent? So in the product side of things, there's no automatic sort of flagging, but within the inbox, you have the option to mark a request as urgent, which will put that request right at the top of the inbox and also flag it with a little flag icon. Bex, do you find that your practice staff kind of use that functionality, or?
We don't tend to, but then having said that, for our practice, we see, I would say 99% of our patients on the same day anyway. So the only thing that we're looking at is it we need eyes on them right now because they might need to go to hospital, or is it they can wait until the child has come back from school and we'll see them at the end of the day. But what we don't do is rag rate hours. I know some practices that do total triage do rag rate. So they cap theirs for the day depending on the number of appointments, and then they wait till everything's in and it's reached the cap, and then they rag rate and say those things that are urgent need to be seen now. Amber things could be later in the week, green things could be kind of routine further down the line, and so on, and they set their own time limits. So there's multiple ways in which you can operate depending on how much capacity you have and the way in which you operate as a practice.
Yeah, definitely. I think that's key as well. A total triage model, it won't necessarily look exactly the same as another practice, which is why we have several ambassadors as part of the ambassador scheme. They are across the country with varying list size, workflows, and clinical systems. So you're bound to find someone that has kind of the most similar kind of demographics and ways of working to you. So do take a look at by scanning that code and booking in a training session. Just conscious that we're at time, but I could be doing this for hours. Oh, the light's turning off in this room as well. I think that's a sign, if anything. I'll just quickly move on, and then we'll end. I just want to thank everyone for joining and giving up some of your time this afternoon to listen to us talk about total triage models. If you are keen to get started, we do have so many resources for you available. So head over to accurx.com/total-triage to access all of those. So we've got a comprehensive training guide that includes things like patient-facing materials, workflow examples, and case studies. You've got your calls with our training ambassador, total triage ambassadors, sorry. And then we've also got implementation training calls, so you can get trained with our team for any additional advice and guidance. We will send out a recording for this session shortly afterwards, so do keep an eye out for that. Bex, thank you so much. I could have done this for hours, but really insightful for hearing about your experience. So thank you so much for sharing that.
You're welcome. And I would say as well, I know when I'm an ambassador for Accurx, but if people want to get in touch directly, they can via my email, which is bex.cottey, Cottey @nhs.net.
That's very nice of you. Thank you so much, Bex. One final thing, we have just recently created a WhatsApp group, a support group for those wishing to move over to Total Triage. Bex and the other ambassadors, as well as people from Accurx, so the team from Accurx are also in that chat, so we're there to support you. We will send a link out for that in the follow-up email as well, so you can join that. But hoping for that to be like a nice resource. I did promise a shout out, so I'm just going to get that in there. I know we're all at time. I did promise a shout out to the first person to respond to my message in that group. So a big shout out to Nayan. I'm a man of my word, so there it is. But yeah, thank you so much everyone for joining, and enjoy the rest of your day. Take care. Thank you, Bex.
You're welcome. Thank you.